And I'm Dilyana Vicheva from
Smell for more than 12 weeks. On the other hand, pediatric chronic rhinosinusitis is characterized by the presence of 2 or more out of 4 symptoms: nasal obstruction, nasal discharge, facial pain and pressure, and cough for more than 12 weeks. The prevalence of chronic rhinosinusitis in children is lower than in adults and estimated to be from 2 to 4%. Etiology and pathogenesis of pediatric CRS is not fully investigated, but the role of adenoids has been demonstrated in many studies. Adenoid hypertrophy may cause a nasal and pharyngeal obstruction and compromise the drainage of postnasal discharge at the nasopharynx. Adenoid tissue was shown to be a bacterial reservoir that contains bacteria identical to main bacterial pediatric rhinosinusitis, especially Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. A study of biofilms using electronic microscopy by Zuliani and Kotters showed the major biofilms were found in 98% adenoids removed from the children with chronic rhinosinusitis, compared with 2% from children with obstructive sleep apnea. Shin and Kotters showed the bacterial isolation rate was increased in association with CRS severity, but not with adenoid size. The role of the osteometal complex occlusion in the etiology and pathogenesis of pediatric CRS is controversial. It is associated with the pathogenesis of CRS in adults due to the presence of anatomical variations, especially those of the lateral nasal wall. However, in the younger pediatric age groups, it is not associated with the extent severity of CRS. However, it may be a factor in age groups from 12 years due to the stronger development of paranasal sinuses and the presence of anatomical variations, especially those of the lateral nasal wall. The underlying inflammatory mechanisms in the pathogenesis of pediatric CRS are different in comparison to adult chronic rhinosinusitis. Adult patients with chronic rhinosinusitis can be divided into two phenotypes: adult patients with chronic rhinosinusitis without nasal polyps, with predomination of the type 1 immune and inflammatory response, and the presence of transforming growth factor beta, interleukin 2, interleukin 10, and the presence of lymphocytes and neutrophils in tissue of the nasal mucosa as dominant inflammatory infiltrate. The second phenotype are adult patients with chronic rhinosinusitis with nasal polyps, with predomination of type 2 immune and inflammatory response, especially interleukin 4, interleukin 5, and interleukin 13, eotaxins, rantes, specific IgE to staphylococcal enterotoxins, and domination of tissue eosinophilia in the nasal and paranasal sinuses mucosa. On the other hand, pediatric CRS patients is characterized by the domination of T and B lymphocytes, eosinophils, macrophages, and tobacco smoke. Children with chronic rhinosinusitis who are exposed to passive smoking present with more severe disease with worse clinical scores. And there is a stronger correlation between asthma and presence of pediatric CRS. The relationship between gastroesophageal reflux disease and pediatric CRS seems to be strong, but the evidence is very weak and doesn't support the routine treatment of GERD in pediatric CRS. Cystic fibrosis is autosomal recessive disease characterized by thick viscous secretions in respiratory tract, the presence of nasal polyps, recurrent respiratory infections, especially those caused by Staphylococcus aureus and Pseudomonas aeruginosa, with gastrointestinal abnormalities and poor weight gain. Physicians should have high index of suspicion for cystic fibrosis when treating the children with nasal polyps. The primary ciliary dyskinesia is autosomal recessive disease in which the children have defects in ciliary beating with impaired mucociliary clearance, with purulent nasal discharge and the presence of nasal polyps and decreased pulmonary function. The main differential diagnostic problems in relation to pediatric CRS are allergic rhinitis and chronic non-allergic rhinitis. The main complaints in pediatric CRS are nasal obstruction, rhinorrhea, cough, and facial pain and pressure. In allergic pediatric patients, the main complaints are nasal itching, sneezing, nasal obstruction, rhinorrhea, and seasonal variation in intensities of symptoms. In chronic non-allergic pediatric rhinitis, the main complaints are nasal itching, sneezing, nasal obstruction, rhinorrhea, and the presence of specific triggers: smoke, mist, cold, dry air, etc. On nasal endoscopy, in pediatric CRS, you can find relevant pathology in the middle meatus, especially thick secretions, pus, polyps, and edema. In patients with allergic rhinitis, generalized mucosal moment, watery rhinorrhea, and nasal hyperreactivity upon endoscopy, and the same endoscopic findings in non-allergic chronic rhinitis. Regarding skin prick test or serum-specific IgE tests, in pediatric CRS patients, those tests are negative or not clinically relevant, exceptionally in cases of association between allergic rhinitis and pediatric CRS. In pediatric allergic rhinitis patients, those tests are positive for allergens, and in non-allergic, those tests are negative for, not clinically relevant for those aeroallergens. Regarding the imaging CT or MRI, in pediatric CRS patients, you can find pacifications of sinuses if those sinuses are developed. And in allergic and non-allergic chronic rhinitis, ideally known. However, in some cases, you can find opacification on CT or MRI of paranasal sinuses. And now, medical treatment of pediatric CRS. Many people think that antibiotics are the main treatment option for the pediatric CRS. But by a review of the literature, I found only 2 randomized studies regarding this topic. The first one was a study performed in the Netherlands, and this was a randomized double-blind placebo-controlled study on 79 patients with chronic rhinosinusitis, aged from 2 to 12 years. All patients were on the therapy by nasal lavage, and 75 patients were randomized into 38 received cefaclor, 20 milligrams per kilograms per day, divided into 3 equal doses, and 37 received placebo for 7 days. In results, there was no significant difference in resolution rate between the children on cefaclor and those on placebo treatment. The second one study was studied by Ino and co-authors, and the authors investigated the effects of a low-dose clarithromycin administered for 8 to 15 weeks in a group of 73 children with chronic rhinosinusitis and otitis media with effusion in doses of 5 to 8 milligrams per kilograms per day, which is 1/2 of normal daily doses in children. Control group consisted of 98 children with the same disease with no therapy. In results, 63 patients from clarithromycin group were free of disease at the end of therapy, but there was no correlation between success of therapy and carriage in the nasopharynx of clarithromycin-resistant Streptococcus pneumoniae. The authors concluded that the efficacy is relating to the potential anti-inflammatory and immunomodulatory effects of macrolide antibiotic clarithromycin, which is independent of its antimicrobial effects. But it is very important to note that this study wasn't a placebo-controlled study. Regarding the use of intranasal corticosteroid in pediatric CRS, by literature review, I found only 1 randomized study. And this was a multinational randomized double-blind study which evaluated the safety of memetazine furoate nasal spray in pediatric patients with bilateral nasal polyps. Group 1 consisted of subjects aged from 6 to 11 years with nasal polyps, received memetazine furoate nasal spray, 100 micrograms once or twice daily, or placebo for 4 months. Group 2 consisted of subjects aged from 12 to 17 years with nasal polyps, received memetazine furoate nasal spray, 200 micrograms once or twice daily or placebo for 4 months. In results, change in 24 urinary free cortisol didn't significantly differ among mometasone furoate and placebo-treated subjects, but mometasone furoate nasal spray administered twice daily in both groups of patients was associated with high reduction from baseline compared to placebo in the polyp size, congestion, rhinorrhea, and postnasal discharge score. The use of systemic corticosteroid in pediatric age groups is a very controversial topic. I found only one randomized study by Osturk and co-authors. This was a double-blind placebo-controlled trial with pediatric CRS patients. 48 patients aged from 6 to 17 years were assigned into 2 groups, and Group 2 received oral amoxicillin clavulanate twice daily for 30 days and oral methylprednisolone for the first 15 days. Group 2 received oral amoxicillin clavulanate twice daily for 30 days and placebo for the first 15 days. In the results, compared to placebo, treatment with steroids resulted in significant improvement in CT scan score, as well as in symptoms of cough, nasal obstruction, postnasal drip, and total symptom score. The use of intranasal saline in the therapy of chronic rhinosinusitis in children is very important, and they and co-authors enrolled 40 children with CRS in a randomized, prospective, double-blind study comparing once daily irrigation with saline or saline with gentamicin for 6 weeks. In results, there were statistically significant and clinically improvement in quality of life scores at 3 at 6 weeks, and reduction in the landmark ACT scores after 6 weeks in both groups, and there were no significant difference between the saline and saline with gentamicin treatment. In conclusion, nasal saline irrigation is effective treatment in therapy with chronic rhinosinusitis, and addition of gentamicin to saline provided no additional benefit. Finally, according to EPOS 2020 criteria, you can find that only intranasal corticosteroid treatment and saline irrigation are recommended for the therapy of chronic pediatric rhinosinusitis. The use of antibiotics is not recommended, and the use of systemic corticosteroids only in exceptional cases. However, surgical treatment still the main treatment options for the therapy of chronic rhinosinusitis in children. In younger pediatric age group, this is adenoidectomy, and in older pediatric age groups, functional endoscopic sinus surgery, especially in pediatric age groups with developed paranasal sinuses. Is there an alternative medical treatment of pediatric chronic rhinosinusitis? High mobility group BOX1 is a pro-inflammatory mediator with important role in the pathogenesis of several inflammatory diseases. In normal conditions, it's located in cell nucleus where it carries out specific structural and metabolic tasks. However, when released extracellularly, it becomes an activator of the innate immunity and strong pro-inflammatory mediator. Microbial antigens, allergens, and endogenous peptides released from damaged or necrotic cells leads to the release of HNGB1, and this free anti-GB1 binds to toll-like receptor 4 and toll-like receptor 9, which leads to activation of transcriptional nuclear factor beta and production and release of pro-inflammatory cytokines and chemokines and attraction of eosinophils and other inflammatory cells to the site of chronic inflammation. HNGB1 has increased expression in the paranasal sinus mucosa of patients with chronic rhinosinusitis in comparison to mucosa of healthy subjects, and the levels of HNGB1 in nasal secretions correlate very well with severity of inflammation, as assessed by the landmark ACT score for CRS. Is maybe glycyrrhetinic acid potential therapy for pediatric CRS? The interest of the scientific community for phytotherapy has grown rapidly in the last 2 decades for 2 main reasons: to find better therapeutic options where they are lacking, and to discover new and safer therapies without adverse events. Glycyrrhetinic acid is the main constituent of the extract of the roots of the licorice or Glycyrrhiza glabra, and this is strong inhibitor of HGB1 as it inhibits the HGB1 hemotachic and mitogenic functions. One previous investigation performed in Italy showed the level of HGB1 is significantly increased in nasal secretions of patients with allergic rhinitis, non-allergic rhinitis with eosinophilia syndrome, and chronic rhinosinusitis with nasal polyps. Glycyrrhetinic acid, according to this study, reduces the HGB1 levels in nasal fluid during the treatment of those chronic eosinophilic inflammations. So glycyrrhetinic acid selectively kills the activated eosinophils and has no effect on neutrophils, macrophages, and lymphocytes, implying the possibility that glycyrrhetinic acid can be a potential treatment option for the pediatric chronic rhinosinusitis with dominant tissue eosinophilia. Glycyrrhetinic acid increases the mucociliary transport time in the patients with chronic nasal inflammation and stimulates the re-epithelialization of nasal mucosa damaged by chronic nasal inflammation. I found no clinical study, randomized study regarding the use of glycyrrhetinic acid in the treatment of pediatric chronic rhinosinusitis, but I found one study regarding the therapy of pediatric allergic rhinitis, and this was a randomized 2-arm study aimed to evaluate the efficacy and safety of the medical device Narivent with glycyrrhetinic acid as a main constituent, in comparison to mometasone furoate nasal spray in the treatment of 40 children with allergic rhinitis aged from 5 to 18 years. Group 1 consisted of 20 children, received 1 puff of Narivent spray into each nostril twice daily for 30 days, and group 2 of 20 children received 1 puff of mometasone furoate nasal spray into each nostril twice daily for 30 days. The intensity of symptoms, nasal obstruction, rhinorrhea, sneezing, and nasal itching, were evaluated by the using of visual analog score. In results, nasal obstruction, rhinorrhea, and sneezing improved significantly in almost equally in both therapy groups. But you can see in the table 6, maybe, Narivent medical device has better safety profile in comparison to mometasone furoate nasal spray. Thank you.
Thank you, Aleksandar. Thank you for your nice review of the medical treatment of the chronic rhinosinusitis. Can you tell us something for sinus microbiome in children? Do you know something? Some new articles about it?
About microbiome in pediatric
Yes, yes, please.
The main bacteria in the microbiome are bacteria related to Haemophilus influenzae, Moraxella catarrhalis, and Streptococcus pneumoniae. According to previous investigations, some topical antibiotics may, in some cases, reduce the number of those bacteria.
Yes, but EPOS 2020 for children is not suggesting local antibiotics in the nose.
Yes.
That's why we have to investigate and to take a nasal swab and to examine. And the new articles.
But the level of evidence is so small, but it is not included in EPOS 2020.
Any questions from audience? Yes, please.
Yes. in some situation, the use of vaccination with pneumococcal vaccine or pneumococcal vaccine in combination with vaccine to Haemophilus influenzae imply to a small number of microbioma with dominant Streptococcus pneumoniae and Haemophilus influenzae, and in the last years the main microbioma in pediatric age groups become Moraxella catarrhalis.
Some more questions? Thank you, Aleksandar. Thank you for excellent presentation.
Thank you.